Good afternoon. So we go to the next chapter on motor central nervous system, that is your motor neuron disease. So this is a degenerative form of disease and is caused basically by the degeneration of the motor neurons of the nervous system. So you know that the central nervous system has got neurons which are sensory as well as motor, and these motor neurons are situated in the precentral gyrus, from where the pyramidal tracts descend and they come up to the spinal cord or to the homologous areas of the brainstem, and there they synapse with another set of neurons which are the lower motor neurons, either the anterior horn cells of the spinal cord or the cranial motor nuclei, which are on the opposite side, because these fibers have already crossed the midline once. And from there the lower motor neuron starts, and this lower motor neuron will start from the anterior horn cells, come out as the motor roots, they join with different motor roots, and from there they form the nerves. Some of these are the pure nerves, pure motor nerves, either your spinal nerves or cranial nerves, or they may be mixed nerves where there is a component of sensory fibers as well. Now, motor neuron disease is basically a degeneration of the upper motor neurons situated in the precentral gyrus, as well as degeneration of the anterior horn cells of the spinal cord and the homologous motor neurons, the lower motor neurons situated in some of the cranial nerves, like the third, fourth, sixth, then seventh, then 12th. So many of these nerves have got motor nuclei. So these will be degenerated. So this is not a common disease. About 2 per 100,000, and is the incidence, and the prevalence is around 7 per 100,000. These are sporadic, but only about 10% are familial, where there are genetic backgrounds. We will not go into the different gene locations, how the disease can be tracked. It's a disease of elderly, more in males, and only about 10% present before the age of 45 years of age. Can you name any famous scientist who are suffering from this disease for a very long time? Anyway, the most common form of motor neuron disease is amyotrophic lateral sclerosis, or ALS, and these terms can sometimes be used interchangeably. So if you say amyotrophic lateral sclerosis, it means motor neuron disease, and vice versa. Why do we say amyotrophic lateral sclerosis? Amyotrophy means trophy of the, or your reduction in the mass of the somatic part of the central nervous system, and lateral because the corticospinal tract traverses down in as lateral parts of the spinal column. And in a patient with this particular disease, if you take a transection of the spinal cord, they will show wasting of the lateral parts of the spinal cord. This is a autopsy finding. So that is why the name is also known as amyotrophic lateral sclerosis. This is characterized by, as I just said, upper and lower motor neuron signs, pure lower motor progressive or upper progressive lateral sclerosis, and there are motor neuron variants which are rare. Some of these we'll be discussing now. Now, what is the pathology? The pathology is death of the anterior horn cells in the spinal cord and in the brainstem homologues, and the upper neuron is destructed, that is the pyramidal tract neuron as well as the fibers. The amyotrophic lateral sclerosis may involve selective loss of function of only the upper or the lower motor neurons at the onset. That means it need not be present globally at the beginning, but it may present focally, and later on it goes on to spread to both the upper motor as well as the lower motor. If in an established patient with amyotrophic lateral sclerosis, you do not have findings of both upper motor and lower motor neuron involvement, then you should put the diagnosis at doubt. And in some subsets, amyotrophic lateral sclerosis arises concurrently with other forms of dementia, including your frontotemporal dementia associated with degeneration of frontotemporal cortical neurons and corresponding cortical atrophy. Why we have discussed this point? Because motor neuron disease, usually the motor or the higher functions will remain intact till the terminal stage of the illness. But in some of these people, you may find some amount of dementia or loss of memory in these particular patients. What are the clinical types of motor neuron disease? As we just described, the most important is your amyotrophic lateral sclerosis. It is basically involvement of the motor neurons of the upper motor neuron as well as the lower motor neuron. So that is the most common variety. The second one is basically a progressive muscular atrophy. It is either the brainstem lower motor neurons or the spinal cord lower motor neurons would be involved primarily, and the upper motor neurons are spared. If it is a brainstem lower motor neuron, we call it a bulbar palsy. If it is a anterior horn cells of the spinal cord, we call it spinal muscular atrophy. It's atrophy because in lower motor neuron degeneration, always you find there will be gross muscular wasting. In upper motor neuron disease, there is usually only disuse atrophy. There is no gross wasting of the muscles. And the third variant is primary lateral sclerosis. This is a variant of upper motor neuron involvement, either of the brainstem neurons or the spinal cord neurons. That means it is the upper motor fibers destined for the cranial nerves, in which case we will call it a pseudobulbar palsy, or it is the corticospinal tract which are degenerated, leading to upper motor paralysis of only the spinal musculature, which is called familial spastic paraplegia. So we have basically 5 subclasses. One is the amyotrophic lateral sclerosis, upper motor and lower motor involvement of the entire nervous system, purely lower motor involvement of the brainstem, we call it bulbar, or of the spinal cord, we call it spinal muscular atrophy, or purely upper motor type without lower motor involvement. If it is affecting only the brainstem nuclei, we call it pseudobulbar palsy. If it is of the spinal cord, upper motor neuron involvement, it is called familial spastic paraplegia. These other 4 variants are less common. The amyotrophic lateral sclerosis is the most common variety among all these. And we will now discuss mainly that area. So what are the characteristics of these based on the classification of the type? If you go to the last variant, amyotrophic lateral sclerosis, it is a mixed lower motor and upper motor type, distal and proximal muscle wasting and weakness, along with fasciculation. There is spasticity, exaggerated reflexes, extensor plantar responses. Now, the upper motor involvement will lead to the spasticity, the exaggerated tendon reflexes and plantar extensors. And the bulbar and the pseudobulbar palsy follow eventually, and pyramidal tract features may predominate at the end. The second variety, which is predominantly a lower motor type, where there is wasting and weakness of the distal limb musculature, along with fasciculation, and the tendon reflexes may be absent. If it is primary lateral sclerosis, there is an upper motor variant of the spinal musculature where there is spasticity. If it is a lower motor variant of the cranial nerves, we find predominantly involvement of the tongue, palate, pharyngeal musculature with dysarthria, dysphagia, wasting and fasciculation of the tongue, and pyramidal signs may be present, may not be present, depending upon how much of upper motor neuron involvement are there. So we find basically 4 or 5 variants of motor neuron disease, of which the last variant, which is amyotrophic lateral sclerosis, is the most common. Now the clinical features of amyotrophic lateral sclerosis. The onset is usually after the age of 50, is very uncommon before 30 years of age. It affects more of males than females. The symptoms: the limb muscles wasting and weakness with cramps and fasciculation because of lower motor features, disturbance of speech, swallowing, dysarthria and dysphagia, and there may be cognitive and behavioral features similar to frontotemporal dementia. So those things may also be present. Among the signs, you will find signs of both upper motor and lower motor. Signs of lower motor would be gross wasting of the muscles with fasciculation and loss of tendon reflexes. And pyramidal tract involvement will give rise to spasticity, increased tendon reflexes and plantar extension. So these two features will be found concurrently in the same person in the same areas. The external ocular muscles and sphincters are usually spared. There is no sensory deficit. These people will not have sensory deficiency, and there is usually no cognitive impairment, which is only common when there is a frontotemporal dementia. The disease is progressive. There is no non-treatment and is ultimately fatal. How do we diagnose the disease? It is initially difficult to diagnose this problem, and there is a lot of differential diagnosis. We will come to that again. The focal patterns of motor neuron disease presents as either a limb onset type or a bulbar onset type or respiratory onset. If it is a limb onset, you will find lower motor type of paralysis found in the hands and the feet. In the feet, you will find foot drop, and in the hands, you will find that a person will fumble with the normal day-to-day activities along with wasting of the muscles and fasciculation. In the bulbar type, the bulbar muscles are basically the muscles of speech and swallowing. So there will be difficulty in speech and there will be difficulty in swallowing. And if there is a respiratory onset, that means the respiratory muscle supplied fibers are affected, there will be respiratory paralysis. And this is usually terminal. Sensory, autonomic and visuals are not common, but whereas cramps can be present. Among the signs, there is a combination of lower motor neuron and upper motor neuron signs of brisk reflexes, wasting, fasciculation without any sensory involvement. Cognitive impairment is present in many of these people. About 10% presents with frontotemporal dementia, and they may progress on to amyotrophic lateral sclerosis within the next few years. The progression is fast and relentless, even with treatment, because there is no specific treatment, and the median survival is about 2 to 3 years, even with the best of treatment. We do investigations mainly to exclude other, just excuse me for 1 minute. One has to exclude the treatable causes, like cervical myeloradiculopathy, if there is a compression of the spinal cord at the cervical region, or if the spinal cord is compressed at the foramen magnum, or chronic lead poisoning, thyrotoxicosis, or sometimes immune-mediated multifocal motor neuropathy. So these are some of the important differential diagnoses that is present. The blood tests are usually present normal, except for mild elevation of the CPK because of destruction of muscles. Nerve conduction studies, both sensory and motor, are normal. There may be a reduced amplitude of the motor action potential due to axonal loss. And Electromyographic studies confirms typical features of widespread denervation and renervation, and lumbar puncture and the CSF are normal, and genetic testing can find out those 10% of people who has got a genetic tendency for development of the disease, which may help in future counseling. See, these people will initially start with weakness of the hands, clumsiness of work, weakness of the feet. They may start with difficulty in speaking, they may be respiratory difficulty initially. Intellect remains more or less normal. There is no sensory involvement. The disease progresses over months. So initially there will be not much of requirement of any help from others. There will be fasciculation of muscles which may be disturbing. So during this phase, most of the time these people will not come to a doctor. By the time they come to the doctor, the muscles will be wasted. They will not be able to carry out most of the motor functions. The sphincters are usually normal, vision is normal, so they don't have much difficulty. Towards the later part, they will have difficulties in defecation, micturition, and respiration. And once the respiratory muscles are being paralyzed, they will have repeated respiratory tract infections, aspiration pneumonia, and sometimes respiratory failure and death. So this is the sequence. So if you consider these people, and there is no specific treatment, so initially they may be only counseling, but later on you require a multidisciplinary service with physiotherapists, people for speech and occupational therapists, dietitians, ventilatory and feeding support, and palliative care teams with neurological and respiratory input. 2 drugs have been found to prolong the life by a couple of months. One is riluzole, the other one is edarafone. These are new drugs. They can prolong the life of the person by a very short period of 2 to 3 months. The non-invasive ventilation significantly prolongs survival. That prevents the asphyxia or hypoxia in these people, as well as prevent aspiration, and improves and maintains the quality of life. Survival and some measures of quality of life are significantly improved in patients having better baseline bulbar function, but not in those with severe bulbar involvement. That means if you found a person with much of limb affections and less of bulbar function, these people would fare better in the long term than those coming with bulbar muscle involvement in the beginning. Feeding can be done by percutaneous gastrostomy, which will also increase the quality of life. And rapid access to palliative care teams is essential for patients as they enter the terminal stages of the disease. Now, another important component that I would just like to give you some idea about this disease is, these people commonly come to you with wasting of the thenar and hypothenar muscles of the hand. Whenever a person comes with wasting of the thenar and hypothenar muscles of the hand, all of them are not having motor neuron disease. Almost 80 to 90% of them are having some form of treatable neuropathy or myopathy. So you have to know the differential diagnosis of the other diseases. So that is the most important thing. And sometimes you get a long note on wasting of the small muscles of the hand. You get a long clinical case on patients coming with wasting of the small muscles of the hand. Nobody may ask you anything about motor neuron disease, and you may be restricted to the other diseases. So what are the possibilities of wasting of the muscles of the hand, the small muscles, especially the thenar and the hypothenar muscles? Let us come from the distal part. It will be easier. Locally, how can the muscles of the hand may be wasted? If they go on for disuse for a long time, let us consider rheumatoid arthritis. In rheumatoid arthritis, there may be restriction of movement and wasting. So here you will find other features of arthritis, deformities of the other joints, along with the serology of rheumatoid arthritis will be positive. So that is how you are going to differentiate. There is no other involvement of the nervous system, both peripheral and central. There could be entrapment neuropathies like carpal tunnel syndrome that will also lead to a wasting of the thenar eminence or thenar muscles. Here what will happen, there will be associated sensory deficit, and it's a typically lower motor type of variant, and on an MRI or an X-ray you will find that the median nerve is compressed. You release the compression, there is almost full recovery. Another important neuropathy is the leprosy. People with leprosy may come with wasting of the small muscles of the hand. There will be non-tender, thickened cutaneous nerves like across the elbow joint, the posterior auricular nerve, or across the head of the fibula. Those nerves may be hard and thick and non-tender. There will be hypoanesthetic patches along with hypopigmentation, or nasal smear or a ear lobule smear will give you positive Hansen's, and it is a treatable disease. Then coming to the brachial plexus, if there is a brachial plexopathy due to any cause, they might lead to a lower motor type of wasting of the small muscles of the hand, and there would be associated sensory and motor deficiency along the spread of the nerve or along the distribution of the roots. From that you will be able to track that this is a disease of the brachial plexus. MRI will be able to help you. If it is compressive, the compression release may be effective. Now comes one of the difficult diagnoses, that is cervical myelopathy. That means in the cervical area, if the cord is compressed, there will be some amount of upper motor neuron lesion in the body, compressing all the nerves or the fibers below that point, including brisk reflexes and plantar extension. But there would be sensory as well as motor deficiencies. And the roots of the cervical 8 and thoracic 1, if they are compressed, the sensory ones will give you anesthesia and root pain. The motor compression will give you wasting of the thenar and hypothenar eminences. So this forms a very important differential diagnosis. This is a much more common disease than motor neuron disease, and this is arrestable and treatable. You can arrest the disease and you can also treat the disease, right? So this is a very important thing you have to know in the differential diagnosis. Now entering into the spinal canal, if there is adhesive arachnoiditis, either due to syphilis or due to tuberculosis, there may be affection of the pyramidal tracts at the cervical, lower cervical and upper thoracic region, along with the roots involvement, leading to upper motor neuron lesion in the lower part of the body and C8T1 compressive features in the hands. So that is another. There is another important differential diagnosis, and that is your syringomyelia or syringobulbia. Now what is syringomyelia? Syrinx means dilated cistern filled with fluid, and sometimes the central nervous system will get some areas where there is degeneration of the fibers which filling up of fluid. If this occurs in the lower cervical and upper thoracic region, especially found in females, syringomyelia, you will find that there is involvement of the roots of the cervical 8 and 1, T1, along with corticospinal tract and other spinothalamic tract involvement from about C8 or C7 downwards. So this pattern you will find in cervical syringomyelia or hematomyelia. If it is a hematomyelia, there is acute bleeding at those areas. So what I can perceive right now is these are some of the important differential diagnoses that you can find in these particular people, and these are basically all treatable. So in our next class, we will go to, we will wrap up the nervous system with the peripheral nerves and your AIDP. So AIDP and peripheral neuropathies is a common chapter which we will try to finish up in one lecture, that is on Monday, and then maybe we will finish with the nervous system, or maybe with the polymyositis is another chapter that will be left out, and brain tumors. Brain tumors is taken up mainly by surgeries, so we will not go in much details except for giving you the symptoms of how to diagnose a brain tumor. So with that, we conclude today. Thank you.